Good afternoon. Welcome back. My name is Kathy Shalou. I'm the clinical director of our outpatient rehab services and also oversee the lymphedema treatment clinic. Very excited this afternoon to talk about lymphedema treatment. That's really where it all begins. Whether we're talking about other medical treatment or surgical intervention, it really starts with treatment of lymphedema, and which is why I'm very excited to introduce our first speaker, Guenter Klose, who's going to be talking about CDT, and that's really where it all starts. Guenter Klose, the name Klose is really synonymous with education of lymphedema therapists. So a lot of the lymphedema therapists out in our audience are very familiar with his name. He was originally trained in the Foldy Clinic and worked at the Foldy Clinic and at other institutions in Germany before coming to the United States and opening a series of outpatient lymphedema treatment clinics. He's known nationally and internationally and recognized for his expertise and invited to speak on the topic, and is also founder of Klose Education and Consulting. He was present at our patient symposium last weekend, really one of the biggest, had the biggest group of attendees at the breakout sessions in the afternoon, patients as well as lymphedema therapists, always eager to hear what he has to say. And he's going to talk to us a little bit about CDT. It's still the gold standard. So please take it away, Guenter.
Hello, and thank you for giving me this opportunity to talk to you about complete decongestive therapy at this important symposium. I am quite aware that this audience does not need a detailed description of what complete decongestive therapy, CDT, is, but I would like to just refresh our memory and say that it is a combination of skincare, manual lymphatic drainage, compression, and exercise. And it is that interrelationship or the interplay of the intensive decongestive phase and the maintenance phase or the self-care phase, which makes this treatment very successful in the long run. Over the last few decades, we have added a lot of components to the treatment of lymphedema. So a lot of modalities were added to complete decongestive therapy, which sometimes makes me wonder how much of the core program of CDT is still being performed on patients with lymphedema. A newly diagnosed patient with lymphedema will likely receive a script which reads lymphedema, evaluate, and treat. And how much of that pure CDT will still be extended to the patient? And that's a question that I would like to explore with you here. Many patients that I'm talking to will say, my therapist has not performed MLD. They were simply bandaging and giving me instructions in exercise and self-care, and perhaps a protocol to perform self-MLD between sessions. Another patient I talked to a couple days ago, she told me that her MLD initially was so light that it did not feel it would make any difference in her lymphedema. And perhaps her MLD was a little bit like the MLD that you see illustrated here in this video. In this video, you see that the practitioner is not using the full potential of her hand. She's not using a great deal of downward pressure or stretch in the tissues. So this will be very inadequate in a patient with any kind of lymphedema. Here is a training video that I use in my trainings, and I try to illustrate that I'm always using the full potential. That means the full surface area of my hand. I'm using way more downward pressure than the person in the first video, and I'm trying to stretch the skin and the underlying tissues enough to provide a stimulation to the collectors, but also move the fluid through the tissues. Even in areas that are awkward to reach, like the medial side of the upper arm, I will try to use the full potential of my hand and use the full surface area with adequate downward pressure and stretching of the tissues. So if you look at these two videos in comparison, you see the difference. And one on the left would be very inadequate manual lymphatic drainage for any kind of lymphedema, and the one on the right would be more adequate lymphatic drainage on patients with, let's say, milder lymphedema. But occasionally we also have to go deeper into the tissues, and we have to perform techniques that will actually break up the induration of the tissues, the skin and the subdermal layer, and the fibrosis. So we use friction techniques, we use S-type strokes. In some occasions we go in with very, very deep pressure just to break up the fibrosis and eventually receive the adequate decongestion of the limb that we are looking for. Here is an example of MLD in a patient with lobular edema. This patient has bilateral lower extremity lobular edema, and the therapist is working really hard with a lot of force and pressure to evacuate some of the free fluid from those tissues before he follows up with more regular MLD strokes. And I hope that you can appreciate the difference in the tissue texture when he now, after a certain amount of time, tries to follow up with more regular MLD strokes, and the tissues are now more decongested and way more receptive to bandaging. But we do have to acknowledge that there is no universal agreement or particular algorithm of how MLD needs to be performed. And so we are counting on the practitioner and their experience to judge how much pressure do we need to be optimally affecting the lymphatic system and decongesting that lymphedema into an area of the body that is not affected with the lymphedema. So another issue that I sometimes encounter when I talk to patients who have received their manual lymphatic drainage in the context of CDT is that patients are only treated in a supine position. And that will greatly shortchange patients like this one here, because you can see that she's already set up with compression, and we can certainly critique the fit of her compression sleeve. That's another lecture. But you can see that her shoulder is very edematous, and she would need to be treated in the posterior quadrants as well. And perhaps if prone position is not possible, at least a side-lying position should be explored with this patient. So for all the lymphedema therapists out there, if you have fallen into that habit of treating the patients only in a supine position, evaluate your patients. The ones who have breast and truncal edema in the front, they likely have a component of lymphedema in the same quadrant of the posterior side. So maybe you want to change your policy and also treat them in a prone or side-lying position. Other therapists have become accustomed to treating their patients with lymphedema fully clothed in a recliner. I would not even consider that MLD, and for sure not expert MLD, that would now contribute to the decongestion of that person's limb. So please do evaluate or reevaluate your treatment approach with patients with lymphedema when it comes to MLD. Here's a person who has done that after she has taken our lymphedema certification course. And evidently, she has treated lymphedema before coming to our course. But then after the course, she writes, I have modified my techniques to those I learned in the course. I'm seeing such improvements with my patients' decongestion. One patient in particular with right lower extremity lymphedema had plateaued or so I thought. With focused MLD for fibrosis and compression wrapping, his calf circumference has further decreased from 48.5 to 42.5 centimeters in just 2 sessions. It is really incredible to witness. So the quality of your MLD, or the MLD that your therapist is providing, can really make a huge difference in the decongestion and the overall outcome of your treatment. Now, let's shift away from talking about manual lymphatic drainage to compression. Nowadays, we have quite a number of tools, compression applications available that we can use and customize to almost every situation that we encounter with our patients. But many times, a treatment protocol for a patient with lymphedema will look like this, where they get 1 or 2 sessions a week. And we have to recognize that the compression system that we use, particularly the short stretch bandages, would only be effective for about 24 hours before they need to be reapplied. In a treatment schedule where the patient comes only like once or twice a week, the bandages can no longer be effective after like 24 hours, because if you accomplished decongestion in the limb, these treatments or these bandages will become ineffective, and the treatment will have to be redone and the bandages will have to be reapplied. Another shortcoming of these 2 times a week treatments is that the patients will oftentimes take the bandages off altogether and not be able to have any kind of like compression from one session or continuous compression from one session until the next. Let's see what the textbook of lymphology says about complete decongestive therapy and the frequency in which a patient should be seen. The textbook of lymphology says during phase 1, the decongestive phase of CDT, the patient must be treated at least once per day. If treatment cannot be given on Sunday, the patient must wear their bandages from Saturday until Monday. Twice a week treatments are doomed to fail. So that makes this approach, once or twice a week lymphedema therapy, not even a valid CDT program. And what I teach in our lymphedema certification course is to rethink how the frequency should be on patients with lymphedema, and that 5 times a week would be the best and most optimal treatment approach for most patients. And we would advocate for 5 times a week for at least 2 weeks. Sometimes, of course, we would need more visits if the lymphedema is more advanced or, more lobular edema in the lower extremity. But on average, 2 weeks will provide a very adequate decongestion where the patient then can be measured for their custom garments, still comes for treatments in the 3rd week and 4th week, but the visits are tapering off. And that, in my opinion, is the most effective and adequate lymphedema treatment schedule that you can apply or provide to a patient with lymphedema. After that, the patient can be discharged with their custom garments already in place. And this patient who has now gone through a 3 or 4 week decongestive therapy program is more encouraged, more motivated to keep the results, perform their self-care, as opposed to someone who has been through the system over 8 weeks, 10 weeks, oftentimes with no results to show for, and is very discouraged with any kind of like transition into a self-care protocol. And when you compare the 2 treatment schedules, we will find that the average number or the total number of visits is shorter when you do the lymphedema therapy in a more condensed version as opposed to dragging it out over many weeks. So it's not even an issue with insurance visits or co-pays for the patient, because the number of visits that will provide more effective treatment are fewer. And here's another email that I received last year. And this therapist reports that because of my nudging and Linda's keynote address at our conference 2 years ago, the hospital has moved towards standardization protocol. Wrapping, that means treating the patient 5 days per week. Since she is a newest therapist, she had to be the pilot project in this hospital, and the results have been outstanding. I have no more to add about this. So once a patient gets discharged, they are very often, because the Lymphedema Treatment Act has not passed yet, forced to buy stockings that are completely inadequate in their care. So part of the CDT protocol is to set the patient up with garments that are adequate in their care and that can actually now prevent the reoccurrence of the edema. If you're using a substandard product that is not adequate for that person's lymphedema, you of course will see the patient back for more treatment in a 6-month period, maybe 9 months or after a year. And that is if you do follow up with your patient. Oftentimes at this point, the patient will get discouraged and will oftentimes abandon their lymphedema treatment protocol altogether. So it is really important that we learn to treat lymphedema more seriously with the tools that are at our disposal. And if the patient cannot readily afford them, that we will find them some avenues to make them affordable for the patient, and that we are not discharging them with inadequate garments, which are sometimes more harmful than helpful in the patient's condition. Now, I would like to spend only a couple minutes talking about terminology and how that could maybe help have better treatment outcomes, because over the last 2 decades, my observation is that cancer-related pure secondary lymphedema, particularly breast cancer-related lymphedema, has been on the decline. But we see an exponential increase in patients with multi-causal lymphedema. And when we treat patients like this, whose lymphedema is likely caused or at least vastly aggravated by their obesity, it is not appropriate to call this lymphedema primary lymphedema. And in our documentation, we should either document it as obesity-induced lymphedema, multifactorial lymphedema, maybe use the word multi-causal edema, or simply chronic edema. And what I try to accomplish by talking about this is that we shift the focus away from the lymphedema, because at this point, the lymphedema is perhaps not the most pressing issue for this patient. We should be focusing on the comorbidities that have led to the lymphedema development in the first place. And I am not saying that the lymphedema should not be treated, but again, oftentimes I feel that CLTs, particularly the ones who are working in a clinic that receives a lot of lower extremity patients, or maybe therapists who are doing home care, they get quite overwhelmed with patients who have obesity-induced lymphedema, multifactorial lymphedema, and now the sole focus of the person's treatment is on the lymphedema. I think we should help them with the lymphedema, but we must also acknowledge and treat the conditions that have led to the lymphedema occurrence in the first place. So while CDT is still standard of care for patients with lymphedema, of course, the gold standard therapy for lymphedema is in the combination of all available treatment modalities, which allow the patient to manage their lymphedema effectively with the least amount of effort and while maintaining the highest quality of life possible. Thank you for your attention.
We'll take any questions if they come in over the chat. Have you?
We have one question. You spoke of garments, and cost can be an issue for some patients. Do you have recommendations or anything else that patients can try if finances are limiting?
Right, finances are always an issue, and I think we need to kind of like be a little creative. For breast cancer related lymphedema, it's a little bit easier because sometimes breast cancer organizations, the ACS, the Susan G. Komen Foundation, they actually have funding for that. I think bigger hospital systems also have funding for indigent patients. And we sometimes have to kind of like make these suggestions. If it's a lower extremity patient and the cost can be really high for daytime, nighttime garments and the combination of this, I think that it is definitely also important that the patient learns how to tap into their resources, maybe community resources, or possibly, Denise, I see you looking. Can you hear me?
No, just miscommunication with my mic.
Oh, okay, with your mic. Okay, not
Yes.
with me.
Sorry, Guenter.
But you can also, encourage people to do a GoFundMe page. This would not be the first time. Some people don't have the skills or the computer savviness to establish that, but maybe have someone in the family who can help them to do a GoFundMe page.
Did you get a question?
Yeah, so my question kind of comes from the inpatient lymphatic therapy perspective. I'm often asked to assist patients with management of their lymphedema in the inpatient setting. And it's, not always feasible to initiate a phase 1, decongestive program. So I find myself kind of grabbing bits and pieces that I can fit into the timeframe that I have. What would your advice be for kind of the best treatment modalities to select in the inpatient setting when you don't really have time for the full treatment program, or could you do more harm than good by not being more complete with your treatment?
Yeah, typically you're not doing any harm, but what I tell my students when this question comes along is you have to decide, is it a good idea to start lymphedema therapy at that time? That patient is likely not admitted because of their lymphedema. So if it's a question where, hey, I can do a little bit of lymphatic care, a little bit of bandaging before the patient gets discharged or transferred to another place, that's great. Sometimes it's better to wait and say, let's take care of the acute issues. Why are you here? Maybe it's a congestive heart failure issue. Maybe it's another internal issue. Let's take care of that. And what I tell my students in the class, and I hope that some of the physicians here would back me up, lymphedema itself, if the patient doesn't have any cellulitis or such things, is never an emergency. So you can easily say, let's take care of the acute issues and then defer the lymphedema therapy for a little bit later.
I have another question, Guenter. What's your opinion using the use of pneumatic compression pumps for patients with lymphedema?
Okay, that question, and I want to say that I have changed my opinion about pumps about 10 times in the last 30 years. And the last time I changed my opinion about pumps is just when the pandemic first hit. When the pandemic first hit us really hard in March 2020, many patients with lymphedema felt very, stranded because they couldn't go to therapy. They couldn't go to see their lymphedema therapist. So I think at that point, a lot of people who had the pump, maybe even stored away in their closet and didn't use it frequently, they would at least have a fallback option. So I think, what we have to remember is it's not a one thing that treats lymphedema. The people who have the resource of a pump, they should use it. They should not be confined to a schedule. Like just this week, 2 days ago, I got an email where a patient was recommended to use the pump 3 times a day for an hour each time. That is an unreasonable pump schedule, I think, for anybody. But when the person has the pump as a fallback option, and they should recognize that there's still a need to see their lymphedema therapist once in a while to monitor on other things, if that makes sense.
I think that's it for questions.
I have one question for you, Guenter. After you conclude an episode of CDT with the patient, do you establish a regular follow-up schedule? Will you monitor them at intervals? And if so, how do you determine what interval, how long to follow up with them?
Of course, an excellent question. I think that a lot of institutions, a lot of private practice people fall short of making that follow-up appointment. Of course, what I would say to my patient is the door is always open. They don't have to wait for that appointment to come around to see me again, but they should actually leave you with an idea of, hey, if everything goes well, then I'm going to see you in 6 months. And that's a reasonable schedule. I mean, no dentist will let you go for more than 6 months before your next cleaning. And I think we need to kind of like adapt this kind of like strategy with our patients with lymphedema, because if you don't walk out the door with that slip in your hand and your appointment made for 6 months, they will likely procrastinate and forget. And then they gradually slip back into, maybe having more lymphedema because their garments become inadequate and so on and so forth. So I think we should see them every 6 months. And if it's more difficult for them because the distances are sometimes, I'm in Colorado here, sometimes the distances are a little bit further than in New England. So then maybe a year, but no one should go longer than a year before they are seen again.
Great advice. Thank you.
We do have one more question. Do we have time?
One more question.
Sure. This is from a therapist. Can you be more specific about the downward pressure that you indicated during MLD for mild lymphedema? I understand that the treatment of, she just completed that. She understood that the treatment of fibrosis will require more pressure. Generally, she's aims for maximum skin stretch, but doesn't really have much downward pressure. Is this incorrect?
I think a little bit more downward pressure than what is commonly done in MLD is warranted. I mean, please don't turn every one of your treatments into a deep tissue massage. That's not what I'm saying. That's not what I'm asking. But I think a little bit more downward pressure is warranted, because we have to remember the original water technique, where kind of like everything sprouts from, was not done on patients with lymphedema. He developed his techniques on all kinds of like conditions, but not lymphedema. And I think Dr. Water himself would probably say, yeah, you're right. In lymphedema, we need a little bit more downward pressure. Don't make it a deep tissue massage every time, but be a little bit stronger so that you kind of like manipulate that tissue that is from, the surface down to the muscle fascia. And I think what drives me a little crazy when I talk to people, they seem to, patients oftentimes say it was like such feather-light touch. And Denise, you and I and everyone here on the panel knows that is not treating lymphedema very well.
Thank you. Thank you, Guenter.
Hey, you're welcome.